series brought to you exclusively by Plexus and Center for Metabolic Surgery. This center, under the guidance of Dr. Raman Goyal, consists of a comprehensive team of surgeons, physicians, dietitians, and psychologists to assist on weight loss surgeries. To all those who follow this series are aware that CMS entails a series of discussions about different clinical aspects in relation to obesity. Now, for today, we would be talking about obesity and liver diseases. Obesity is associated with a range of liver abnormalities, leading to a severe health concern. The increase in the prevalence of obesity is responsible for the increase in cases of non-alcoholic fatty liver disease, that is NAFLD, as well. Therefore, understanding the pathogenesis of obesity is an essential foundation for clinicians to manage the disease. For this, we would first hear from Dr. Amit Gupte. Dr. Amit Gupte is a notable gastroenterologist and hepatologist consultant at global hospitals in Mumbai with over 16 years of experience. His expertise lies in the field of gallbladder, biliary stone, inflammatory bowel disease, jaundice, colitis, and gastroscopy treatments. So, welcome, Dr. Gupte.
Good evening, everyone. I am Dr. Amit Gupte. I am a consultant hepatologist at Global Hospital, Mumbai. I would like to thank, first of all, Dr. Plexus and Dr. Raman Goyal for giving me this opportunity to speak to you. So, the topic for discussion today is obesity and associated liver disorders. And one thing that comes straightforward is NAFLD, which we are very aware of, and it's very common. So, let's go ahead and discuss this. So a few basic rules that we need to remember when we see patients of fatty liver, or mostly we get reports of sonography saying USG suggestive of fatty liver. So rule number one is that all that looks fatty on imaging is not fat. So the fatty liver looks hypodense on a CT scan or hyperechoic on a sonography. So apart from fatty liver, there are other differential diagnoses to it like amyloidosis, tuberculosis, sarcoidosis. These are not very common, obviously, but one needs to keep this in mind that imaging hyperechoic liver is not always fatty liver. Rule number two is that all that is fat is not NAFLD. So again, we know all this. There is something called macrovesicular steatosis and microvesicular steatosis. So you can see in macrovesicular steatosis, the fat globules in the liver cells are really big. They occupy the entire liver cell. And in microvesicular steatosis, as you can see in this the right hand image, that there are small vesicles of fat. So the macrovesicular steatosis is actually what is NAFLD, or non-alcoholic fatty liver disease, what we commonly encounter as fatty liver. The microvesicular steatosis has many other pathogenetic factors, and it is not NAFLD. It is a diverse disease altogether. So macrovesicular steatosis can be alcohol-induced. It can be seen in hepatitis C, particularly genotype 3, Wilson's disease, patients on parenteral nutrition, and certain drugs. Microvesicular steatosis, on the other hand, is like Ray's syndrome, AFLP, HELP syndrome, and again some drugs. So coming to the point here is NAFLD, and what is the spectrum of NAFLD? So many patients will have NAFL, that is non-alcoholic fatty liver, where there is just steatosis. It is not causing any liver injury or any liver fibrosis. In some patients, it will progress to NASH, that is non-alcoholic steatohepatitis, which may progress to cirrhosis, and some of the patients may develop HCC or hepatocellular carcinoma. So most of the patients will be essentially having non-alcoholic fatty liver, which will usually be harmless. So the pathogenesis wise, the first hit is formation of steatosis. So if there is steatosis, then it will progress further. So the liver gets inflow of the lipids through diet, through the adipocytes in the other parts of the body, the free fatty acids coming into the liver cells, which are then taken care of by beta oxidation or converting into phospholipids, triglycerides, and secretion by VLDL. So if there is an imbalance in the inflow of these fatty acids to the liver and the outflow as the liver uses them, the fat gets accumulated and causes steatosis. Now, once there is steatosis, there are other factors like insulin resistance, which is a central in the pathogenesis of NAFLD, and the free fatty acids, which can cause a downstream free radical damage and inflammatory pathway mediated injury, which can ultimately cause stellate cell activation, fibrosis, and cirrhosis. So the first step is formation of steatosis, and second step is this steatosis then causing liver injury, which can progress to fibrosis and cirrhosis. So there are many studies. I have picked a few which will highlight what is the problem or what is the prevalence of NAFLD in our population. So this was one study which had around about 300 subjects screened, and the mean BMI was 29. 46% of them were found to have NAFLD. Now this study utilized biopsies also. So it is a very sort of a rare study where you have biopsies for screening. So NAFLD was found in 46%, and NASH, that is non-alcoholic steatohepatitis, that is the worrisome stage, was present in 30% of those who had fatty liver on ingestion. In patients of diabetes, NAFLD 74% and NASH was 22%. So there was this is one very good study by Dr. S.P. Singh. So 159 asymptomatic healthy relatives of patients who had come to the hospital were screened by doing USG, and almost 25% of them had fatty liver on sonography. So the BMI was a bit higher, 25.9 in those with fatty liver and 22 in those without fatty liver. So I think this corresponds to our daily practice that we see is almost 25 to 30% of the patients will just walk in with a sonography report of fatty liver, and that sonography has been done for some other reason. Obesity, severe obesity, which patients do come for bariatric surgery, almost 90% of them have NAFLD, and 5% of them will have unsuspected cirrhosis, which is found during evaluation for bariatric surgery. Diabetes, almost 50%, this is Indian data, 50% will have NAFLD, and 70% is the Western data who have NAFLD. Dyslipidemia, almost 50% of patients with dyslipidemia will have NAFLD. Now, if you see the natural history of NAFLD, as I told you earlier, majority of them will be non-NASH and stable. So just steatosis, no implications at all. But some of them will develop non-alcoholic steatohepatitis, and out of them, around 70% will be stable, will not have much of progression. But around 30% will develop fibrosis, and 20% of them will go on to form cirrhosis, and then cirrhosis will ultimately have its own attendant complications. So what is the most important differential diagnosis in patients whom you see fatty liver? The most important differential diagnosis is alcoholic liver injury. So no investigation can reliably distinguish between the two except for a good clinical history. So if alcohol consumption is less than 30 grams per day in men and less than 20 grams per day in women, then non-alcoholic fatty liver disease is the possibility. This is by the ASLD guidelines 2012. So which are the tests that we usually do? So no tests are specific for NASH. We do the LFT, in which we have liver enzymes, AST, ALT. They cannot quantify how much is the fat, but yes, they will tell us that there is inflammation. If AST, ALT is elevated, then these patients are more likely to have NASH rather than NAFL. If AST is more than ALT, then that indicates that probably there is some underlying fibrosis also. So these tests can help you to determine a problem if they are abnormal, but they can still be normal in presence of NASH. So usually we see these reports: grade 1 fatty liver where the liver is brighter than the renal cortex, grade 2 fatty liver where the brightness of liver obscures the portal vein branches, the echogenesis of portal vein branches, and grade 3 is where the liver or the brightness of the liver on sonography will obscure the diaphragm outline. So usually we see this report. So grade 1, grade 2, grade 3 fatty liver on sonography. So USG is a very important and a easily available radiation-free, inexpensive steatosis or whether you have a NASH. So that is one important limitation that we have on sonography. CT scan, again, the liver, you can see that there is an index called liver attenuation index, by which you can judge the amount of steatosis which is there. We usually use this in transplant donors, living donors, to assess how much fat is there and whether they are suitable for living donor transplant. MR spectroscopy is much more reliable, much more accurate tool to quantify the steatosis. It will tell us how much fat is there in the liver. But the problem is it is not easily available, and it will just tell us whether there is fat and how much fat. So we get reports like 10% steatosis, 30% steatosis. But again, it cannot differentiate between NAFL and NASH. Fibroscan is one test which has been available now since last 10 years or so, and the stiffness tells us whether the fibrosis has set in or not. So the threshold is 7.9. If you have a stiffness of less than 7.9, then usually there is no fibrosis, and if the stiffness is around 12, 13 in that range, then probably cirrhosis has started to set in already. The problem with transient elastography or fibroscan is that you can screen only one particular segment or a cylinder of the liver. You cannot screen the entire liver. That is one limitation, and because the disease can be patchy, it is slightly difficult to judge the situation of the entire liver. Fibroscan also gives us control attenuation parameter, which can now quantify steatosis, but it is not as accurate as the MR elastography or the MR spectroscopy. This is one more test called ARFI, which is a sonography-based test, and depending upon the score or the speed of the mechanical wave that travels through the liver, you can judge whether there is fibrosis or not, or whether there is steatosis. So if you get values less than 0.8, it is likely to be steatosis, and if there is significant fibrosis, then you get higher scores. Like more than 1.26 suggests significant fibrosis. There are various scores which are there based on various non-invasive markers which can help us to identify whether which patients are at high risk of fibrosis. The most easiest one is NAFLD score, NAFLD fibrosis score. This is an online calculator where you have age, BMI, diabetes, AST/ALT, platelets, albumin, and you enter the values and you get the answer. So if your score is less than minus 1.4, then there is usually absence of fibrosis. If your score is more than that, then probably there is some fibrosis going on in the liver, and you can prioritize these patients for care and be more aggressive with their treatment. So how can we distinguish between NAFL and NASH? This is the most important thing that we need to understand. So if there is AST and ALT levels are high, then you know that probably this is NASH. But if they are normal, it doesn't rule out NASH. So which are the patients who are at high risk of NASH? Presence of metabolic syndrome, elevated ALT, and elevated cytokeratin 18. These patients are at high risk of having NASH. But the only test that can reliably distinguish is a biopsy. So whether we do biopsy in all patients, what is the role of liver biopsy? So a liver biopsy is now not used much. We can judge whether the patient is having a non-alcoholic steatohepatitis based on the clinical features, like as I told you, high BMI, presence of hypertension, elevated ALT, or presence of early fibrosis on Fibroscan or MRE. So usually biopsy is not much needed in clinical practice. So only if there are unusual features and we need confirmation of diagnosis, then usually we subject patients to biopsy. Otherwise, it is not much used as such. So how do we manage patients of NAFLD or NASH? So most important thing, so the most important thing here is lifestyle modification, weight loss. So if you achieve around 3 to 5% of weight loss, then if there is just steatosis, then it will improve. You need up to 10% weight loss to improve NASH. So diet, exercise, lifestyle modifications, avoiding simple carbohydrates, simple things like aerobic exercise, and the whole focus should be weight loss. So once you lose weight, then there is chance that NAFL or NASH can improve. The pharmacotherapy which is there is metabolic, the drugs which act on metabolic pathway, that is metformin, pioglitazone. We know these drugs, these have been used for treatment of diabetes. And there are studies where metformin and pioglitazone have been shown to improve steatosis or hepatocyte ballooning, but they are not very effective in reducing inflammation or fibrosis. So they may just help to reduce the steatosis component, but they are not useful for treatment of steatohepatitis. And again, concerns with pioglitazone to be used in cardiac patients, and most of the NAFLD patients will have cardiac components. So these drugs are now not much used in routine clinical practice. Vitamin E has been the drug which has been used extensively. It is an antioxidant, and it acts at the second hit. So free radical damage and lipid peroxidation, it being an antioxidant decreases those steps and helps in improving the NAFLD. So if you can see here, patients who have received vitamin E versus placebo, or there is the parallel study was pioglitazone with placebo. So they have improved steatosis, they have improved ballooning, and they have improved inflammation also. But again, vitamin E has not been shown to improve fibrosis. So if there is fibrosis, then vitamin E probably cannot reverse that fibrosis. There are new drugs which are coming up. Elafibranor is coming up. Saroglitazar already is there in clinical practice. We have been using it routinely in NAFLD patients. It is a PPAR alpha gamma agonist. It has been approved for treatment of diabetic dyslipidemia. There are trials which have shown it improves the inflammation also. But again, it doesn't have much effect on reversing fibrosis. So the focus here in prevention is to identify patients who are in early fibrosis and guide them with aggressive lifestyle modification and weight loss, so that at least their fibrosis can be stabilized, or in some cases it may regress. Obeticholic acid is also come up. It is a FXR agonist, has been used for treatment of NAFLD. But again, not used in established cirrhosis. It is used only in F2, F3 fibrosis as of now. So I think the role of bariatric surgery will be covered by Dr. Raman Goel, but the point to highlight here is weight loss that can be achieved by bariatric surgery has been shown to improve steatosis, inflammation, as well as this meta-analysis showed that almost 65% had improvement in fibrosis. So the sheer degree of weight loss that you can achieve through these bariatric procedures can somehow has been shown to resolve the fibrosis also. But having said that, bariatric surgeries have still not become a standard of care for just fatty liver. If there is just NAFLD, then probably it is not recommended to do bariatric surgery unless there are other indications for bariatric surgery. So there is this consensus which we all know that in Indians, the definitions of normal overweight and obesity are much different than the Western counterpart. And here we see that Indian patients who have BMI of 25 have similar risk profile as Westerners who have a BMI of 30. So the consensus statement by the Indian Society suggested obesity to be defined as more than 25 in Indians, and this is something that is important. Somehow Indians being at a more risk metabolically, even at a lower BMI. So there is something called as lean NASH. There was a study where they had 150 NAFLD patients, and they divided them into three groups. Group one was clearly overweight or obese. Group two had normal BMI, but they had abdominal obesity. That is, they had the if you see by the Indian definition, waist circumference more than 90 for men and more than 80 for women. So that is the as per the definition of abdominal obesity. So group two were patients who had normal BMI but had abdominal obesity, and group three were patients had normal BMI also and they didn't have any abdominal obesity also. And they found that group one was clearly 80% had NAFLD, group two 5% had NAFLD. Group three, which is like no normal BMI and no abdominal obesity also, still 15% of them had NAFLD. So this is what is called as lean NAFLD. And surprisingly, if you see, 80% of group 3 had insulin resistance and 17% had metabolic syndrome. I don't have any explanation for this observation, but these patients are probably thought to be physically lean and metabolically obese. And the treatment or the prognosis wise these patients, how they behave and what should be the goal of treatment in these patients is not yet fully established. So summarizing, so basically in NASH, if someone has BMI less than 40 or more than 35 without comorbidities, like basically who are not otherwise candidates for bariatric surgery, if they don't have any cirrhosis, then the primary and most important treatment would be lifestyle modifications and pharmacotherapy. And if there is child age cirrhosis, then lifestyle changes and evaluation to rule out other causes of cirrhosis. If someone has decompensated cirrhosis, then obviously lifestyle changes and these patients need to be evaluated for a liver transplant. Regarding management of patients who have obesity and otherwise they have indications for bariatric surgery, if they don't have any cirrhosis, then the treatment will be clearly bariatric surgery, which will take care of the obesity, the other comorbidities, as well as the NAFLD. Childless cirrhotics who are obese and candidates for bariatric surgery can still be performed in them. The risk factor will be slightly higher, but carefully selected patients in large volume centers should do well. And in these patients, the cirrhosis would also have some impact by the weight loss that is achieved by bariatric surgery. Patients who have decompensated cirrhotics and obesity, then obviously surgery is not an option. Lifestyle changes and they need to be evaluated for a liver transplant. So that's it. Thank you. And we can have any questions if you have.
Thank you so much, Dr. Gupte. So we have a couple of questions.
Yeah.
So my first question is, what is the risk factor for liver disease due to obesity?
So as I discussed, see, basically obesity is one manifestation of the larger metabolic syndrome that is there. So this metabolic syndrome affects multiple organs. So liver is one of the organs which is affected by metabolic syndrome. Central to this is insulin resistance. So most of the obese patients will have insulin resistance, which will lead to accumulation of fat in the liver, what we call fatty liver. And some of these patients where the excess accumulation of fat will trigger inflammatory pathways and cause liver injury. So which can develop into steatohepatitis, where there is inflammation, and which can further lead to fibrosis and cirrhosis. So yes, obesity, and in fact, if you see studies where patients who had severe obesity, almost 90% of them have NAFLD, and almost 5% of them will have undiagnosed or cirrhosis found for the first time when they are evaluated for surgery. So definitely obesity will have impact on the liver.
So my second question is the liver damage caused due to obesity reversible?
To some extent, yes. So the fatty liver is always the spectrum of the disease is non-alcoholic fatty liver, where there will be just steatosis, no inflammation. This is definitely reversible if you lose weight, lifestyle modification, weight loss. So decrease in the amount of steatosis is definitely possible. You don't need to lose much weight. At least if you lose 5% of your weight, then the steatosis component can resolve. If patient are in a bit advanced stage like non-alcoholic steatohepatitis, this also can resolve by weight loss and medications which are available. You need to achieve a higher amount of weight loss, at least 5 to 10% of weight loss to for the inflammation to settle. So these two stages are reversible. The next stage is the stage of fibrosis, where due to continued inflammation, now the liver forms fibrotic bands. This stage may not be completely reversible. Now, actually, the recent literature which is available shows that early fibrotic stages may revert. So, if you have F1, F2 fibrosis, it may revert by weight loss and all these measures. Most importantly, would be lifestyle modification and weight loss. If there is established cirrhosis, then it is not going to revert with whatever you do. But these measures will still be needed to decrease or prevent or I would say slow down the progression of the disease. So yes, NAFL, NASH and early fibrosis are still reversible by appropriate treatment.
Thank you, sir. My next question is what is fatty liver and how can it be cured?
So fatty liver is simple, just accumulation of fat in the liver, which can cause liver injury. How can it be cured? The most important thing that underlies all the treatment of fatty liver is weight loss and nutrition management and lifestyle modification. That is the most important thing. Pharmacotherapy has been there, and there are so many drugs that have been tried previously, and there are so many drugs already in the trial. Now, none of these drugs is clearly a game changer as of now. None of these drugs can reverse fibrosis as of now. So the best way to approach these patients is to identify early and try to control early so that we catch them in the reversible stage and then prevent the progression. Because once there is established cirrhosis, then that cannot be reversed. But yes, the early stages can be reverted by lifestyle modification, weight loss, nutrition management, and by pharmacotherapy also.
Sure, sir. One last question. So, how are obesity and liver diseases managed?
So, as I explained in my last slide, the usually obesity, the first sort of thing is nutrition management, diet, exercise, weight loss. Patients who are severely obese or morbidly obese with comorbidities, the treatment of choice is bariatric surgery because there are limitations in these patients to achieve that sort of exercise levels. So the treatment of choice in these patients with severe obesity and severe obesity with comorbidities is bariatric surgery. If these patients have fatty liver, which most of them will have, then we need to find out in which stage they are. If they are NAFL, NASH, or fibrosis, or even child A cirrhosis, these patients can undergo bariatric surgery. Patients who are beyond that, patients who are decompensating cirrhotics, surgery is not an option because the risk associated with the surgery will be very high. And these patients need to be managed by lifestyle modifications. And if the liver disease is decompensated, patient is developing complications due to cirrhosis, like ascites formation or GI bleed, encephalopathy, then these patients need to be considered for a liver transplant.
Sure, sir. I think these are all the questions that we had. So, thank you so much. So, a very well lecture by Dr. Gupte. Moving on to the second part of the session, we would have Dr. Raman Goyal, under whose leadership we are conducting these programs every week, who's also the director and of bariatric surgery at Wokhad Hospital, Mumbai, to shed some light on bariatric surgery and liver disease. So, over to you, sir.
Thank you, Dr. Darshika. I think Dr. Gupte has been very specific and very elaborate in his comments on fatty liver and how it progresses. And he has also done my job by talking about the role of bariatric surgery. I'll share a presentation which has some of the common studies or slides. But that apart, what is known is that there are not many treatment for fatty liver except by weight loss. And people who are significantly overweight, there is a possibility of offering bariatric surgery. But people who are normal weight to just being overweight, there is no other treatment except to go for a lifestyle measure. So I'll quickly start my brief presentation and then we can take few questions.
Yes, sir.
So what is the impact of bariatric surgery on liver? So as Dr. Gupte very nicely mentioned, fatty liver could be because of any of these things. Fatty liver could be because of weight gain. It could be because of metabolic changes. So somebody has dyslipidemia, somebody has diabetes. Then there are inflammatory diseases, as he mentioned. And somebody who is taking alcohol, I mean, it's a separate disease, but it presents as fatty liver. So if somebody is consistently having large quantity of alcohol on a daily basis, then is likely to have a alcoholic liver disease, which also presents as a fatty liver. Now, as mentioned, there are not many medicines to treat fatty liver. I mean, there are medicines which are used by Ayurvedic practitioners. There are medicines which are used for diabetes and also helps in improvement of fatty liver. But there are no directly approved medicine for fatty liver treatment. So we are left with these two options. That is, the person can have a lifestyle changes to lose weight, or can have bariatric surgery to lose weight, and the fatty liver improves. Now, there are various studies which have shown that if person loses just 3 to 5% of the weight, then the fatty liver improves. But he needs to lose 10% of the weight to improve the inflammation or to improve the NASH. And these lifestyle changes includes avoidance of simple carbohydrate, to have hypocalorie diet, to exercise on a regular basis, and to avoid smoking and or alcohol. So all these lifestyle changes are required together to have a impact on the fatty liver or on the NASH. But the problem is lifestyle changes are not sustainable. There are various studies which show that within 1 year, 92% of those who are overweight will regain their weight, and 98% of those who are morbidly obese will regain weight after lifestyle changes. So whether you put person on diet or medicine, they are usually not associated with long-term weight loss. As far as bariatric surgery is concerned, these are our publications, which shows that at 3 years after sleeve gastrectomy, almost 72% weight loss, and after bypass, almost 86% weight loss, which is substantial, because here we are on the diet side, we were talking of 92 to 98% patients regaining their weight within 1 year. Here we are talking of that even after 3 years, they are losing around 72 to 86% of their extra weight. And it's not only about weight loss, it's also about diabetes resolution, which is one of the factors for fatty liver. So our studies have shown that with sleeve, 80% patients who are diabetic will be very well controlled and they will not require medicine. And 92% of bypass patients will not require medicine for diabetes. And even after 5 years, almost 65% patients will not require medicine for diabetes for those who have undergone sleeve gastrectomy. So bariatric surgery works on fatty liver through various mechanisms. It's not only just weight loss, but there are various mechanisms, including diabetes control, including dyslipidemia control. Because there are many other mechanisms by which it works: lipid control, reducing inflammation, it reduces cancer risk, and then obviously it leads to longevity. Now in India, the guidelines have been modified twice in last 15 years. And the current guideline says that if somebody is just about 20-25 kg overweight, he or she can undergo a surgery, even without any comorbidities. So if the person has, let's say, a fatty liver, which is not considered a comorbidity, but is 35 BMI, we can offer this surgery and his fatty liver or NASH can improve. If somebody's BMI is 30 and has significant comorbidity, then we can offer this surgery. And if somebody is just diabetic with 27.5 BMI, we can offer this surgery. So in Indian scenario, as Dr. Gupte was saying, our cutoffs are lower. These surgeries have been advised at a lower cutoff levels, primarily to help the patient lead a healthy life rather than suffer from it for a long time. These are various types of surgeries which most of you know: sleeve gastrectomy, a ruined gastric bypass, and a mini gastric bypass. And usually in first month itself, patients lose 10% of their total weight. That means if person was 150 kg before surgery, is likely to lose 15 kgs in first month, and then 5% every month. And overall, they lose between 70 to 80% of their extra weight within a year or year and a half. So it causes significant weight loss, and obviously it helps in various comorbidities resolution. Now, how does the fatty liver or NAFLD improves after bariatric surgery? Because there is a reduced dyslipidemia, the cholesterols improve, HDL increases, LDL decreases. There is improved glycemic control. So there is decreased peripheral and hepatic insulin secretion, improved insulin secretion, and there is decreased inflammation. All this, along with weight loss, helps in remission of NAFLD. Now, this study was shown by Dr. Gupte that where these patients who had bariatric surgery, their liver biopsies were done before surgery and after surgery. And they have shown, besides improvement in fatty liver and NASH, 65% of the patients who had early fibrosis, the fibrosis could be reversed, which is a very significant finding, because usually with no other intervention, cirrhosis can be reversed. And this is feasible only if they are treated early and they are treated with a bariatric surgery. Again, this slide was shown by Dr. Gupte. So NASH with BMI in India, BMI between 30 to 35, we can offer this surgery even in patients with childhood cirrhosis, because the only way to avoid a liver transplant in this patient is through a bariatric surgery. Otherwise, generally, childhood cirrhosis is a progressive disease and can decompensate or go into a child B cirrhosis, and patient may end up with a liver transplant. There is a lot of apprehension among people about the risk of surgery, but over a period of time, as I show the studies here, it has been established that the bariatric surgical risk has reduced substantially, and it's at par with the surgery of a gallbladder. And it is also established that there is a lower risk in busy centers, those who are doing at least 100 bariatric surgeries a year. And the deficiencies are not common. They are actually very uncommon. They only happen if somebody doesn't follow the advice of they don't take vitamin supplements after bariatric surgery. Otherwise, they remain healthy. Last 2 or 3 slides. It's not about for last 1 year. Most of the patients are being paid either by the insurance companies or by their corporates or through their family floater policy or by the governments. So all these are third-party payments where patients are not paying, and it is now happening in almost 80% of the patients. For those physicians who want to know what is the insurance eligibility, so if BMI is more than 40, then patient can directly get the surgery done under cashless route or reimbursement route. Or if BMI is more than 35 and they have one of these 4 comorbidity, that means if they have cardiomyopathy or if they have coronary artery disease, heart disease, or if they have severe sleep apnea, or if the patient has uncontrolled type 2 diabetes, then even with BMI more than 35, insurance companies usually pay comfortably. So friends, to conclude, take-home messages: bariatric surgery remains the only sustainable weight loss tool. There is significant improvement in diabetes, cholesterol, and inflammation after bariatric surgery, and it's probably the only tool to treat fatty liver and to reduce risk of liver failure or hepatoma in future. So I conclude my presentation here, and since this is the last of our series of sessions which have been going on for almost 5 months now, I thank all the family physicians who have logged in on a regular basis and watched these programs, because that has encouraged us. And this was not about bariatric surgery, this was about obesity and how it correlates to various diseases. And I wish also to thank the Doc Plexus management, the technical team, my anchors, Dr. Darshika, to help felicitate these programs. Dr. Darshika, over to you. If you have any questions, I'll be very happy to answer.
Yeah, so thank you so much, sir. I think most of the questions were covered by Dr. Gupte, but we have one more question, which is from Dr. Ahmad. He says, what is the risk factor for liver disease due to obesity?
Well, I think this has been spoken again and again. The risk factor increases substantially. And even people who are not very BMI-wise very high, but if they have central obesity, the fatty liver happens. And as Dr. Gupte was showing, so fatty liver is just deposition of fat in the liver. But if there is a deposition of fat, 30% of them will end up with NASH, all right, which means an inflammatory disease. And 30% of those who have NASH will end up with cirrhosis. So we are looking at, if we are looking at 100 obese people, 10% of them will end up with cirrhosis, which is very big, which is bigger than the alcoholic liver disease, because alcoholic liver disease is not that rampant in our country as the obesity and NASH. So I think the risk is substantial, and it's not only question of cirrhosis; it's also question of hepatoma. They can have tumors of the liver if they have fibrosis in the liver. So I think gradually there is a realization settling in the minds of physicians and public at large that fatty liver is not to be taken lightly. It's not only a question of how you look cosmetically. Obesity kills, and obesity kills in a very quiet way, because there is hardly any diagnosis of somebody dying of obesity, but people die of diabetes, people die of heart attack, people die of liver failures, people die of kidney failures, people die of brain strokes. And all these are ultimately, the mother of all diseases is obesity, which is leading to all these problems in longer run.
Very well said, sir. Sir, these were the questions that we had, but I want to invite Dr. Mr. Nizar Thanawal here, who's been kind enough and he's been waiting for, I think he's done. So Mr. Nizar, if you could just unmute yourself.
Yeah, can you hear me?
Yes, very clearly. So I just want to know from you, what led to your mind to make up for the bariatric surgery with, of course, Dr. Raman Goel?
Yeah, at the time of before surgery, I was around 150 kg weight, with having a very sleep apnea, heavy sleep apnea, very high diabetes, blood pressure and all. So I went to Mr. Raman Goyal, and he suggested me to do the operation immediately, because the sleep apnea was very high. You know, in 6 hours, I was going to unconsciousness in my sleep around 450 times in 6 hours. I used to go in coma, and that was very serious. Sometimes I may not get up, so I have to do the operation that time. And immediately I have gone through the operation in Bombay Hospital by Mr. Raman Goyal. And Dr. Goyal was very, was very kind to me, and I was very, only 10% was my chance of coming out alive. But we gave ourselves to doctor, and he really have done his good job, and my life has been saved. And after operation, my weight went down up to I think so 86 kg. Yeah, it went down up to 86 kg, and now I'm at around 89. And I've done the operation, I think so. I've gone through it around 2008 November or December something.
Okay.
So that is exactly around 14 years back.
Which is a
and
good
I have maintained it well. Yeah.
So, sir, do you face any difference in terms of your mental and physical, social circle, and like your confidence that might have gained through?
Of course, I am totally very much positive, because before going through my operation, I was thinking about committing a suicide.
Okay.
Yeah, because I could not even do my business and all. I could not. I was in partnership firm in a soft drink, so nobody was considering me as a partner or as a. So I was just like a scrap person. So I thought to end my life at that time. Then we met Dr. Goyal, and he have gone through the operation, and then my lifestyle is totally changed. Now I'm migrating towards Canada. I was there in 1 year back, so I just came here last month, and we are all family are going to Canada. My half family are there, and my elder son and I'm here to sort of to sell out all the business and all. Yeah. So everything has changed. Yeah, positively.
Also, sir, what kind of lifestyle modifications that you had to go through after the surgery was done?
What kind of lifestyle means?
So, as in, did you make any major changes in your lifestyle in terms of what you were eating, in terms of how active you were after the surgery to maintain, of course, because you've maintained the weight for almost now 10, 12 years?
Yeah, of course. I used to go to gym, and in terms of diet, I have not exceeded to the limit. At present also, in one meal, I just take 2 chapati, not more than 2 chapati. And if I have to take rice, then I skip chapati. I eat only rice. And there is one negative points also. I like chocolates and all, but I maintain my diet and all. Yeah. So lifestyle is totally changed. I go to gym. I go for a walk. I walk for 1.5 hours at one time. Yeah. So 3 to 4 kilometers I walk once in the morning, and 1.5 kilometers at night. So I maintain it. Yeah.
Okay. Thank you so much, Mr. Nizar, for joining us here. Dr. Goyal, if you want to say anything to him, I think before we conclude. Sir, if you could unmute, I think you're.
Yeah, so Nizar has been a very confident and forward-looking patient for us. He was among the first few who had a gastric bypass, because we started gastric bypass somewhere in 2005 and he underwent in 2008, as he says. And he had really a bad sleep apnea. But the best part was that he maintained his lifestyle, changed lifestyle for so many years. He's a big businessman from Gujarat, and he would own a soft drink manufacturing company, and also he would travel a lot. And I remember he told me about 2 years after the surgery that his business has increased almost 20% because his mobility has increased. So earlier he would not go and meet the distributors because of his weight and limitations, and that he improved that. And I have seen him up close because he has been attending all our support group meetings when he was, till the time he was in India. And I have visited his hometown and met his entire family also. So I know that such people can prove that bariatric surgery, if used wisely, can be a life transformer. I didn't know this about what he said about his suicidal thoughts, which I'm hearing first time. But what I can say today is that he's looking forward. You know, his entire family is migrating to Canada. He's looking to a better life. And so my best wishes to Nizar and his family, and thanks
Thank you,
for
sir.
being a good patient and always
Thank you.
willing to come forward. You know, he was part of our foundation that we created for supporting patients. And so I wish him good luck in future. And you know, just because he speaks out, so many people will be benefited. You know, the doctors who are listening to this program will have confidence listening to Ms. Nizar and will tell their patients. And Nizar will not even know how many hundreds and thousands of patients across this country benefited because he spoke out today. So thank you so much, Nizar.
Thank you, sir. Thank you.
Also, sir, any closing remarks for our audience here, since it is our final program this week?
So I think since the audience is mostly doctors, I would say let's start taking obesity more seriously. Let's keep the biases out. Obesity is loaded with so many biases that even qualified people say that, you know, this person should be eating less, this person should be eating healthy, this person should be exercising, without appreciating that biology or physiology is the main reason for weight gain. So the purpose of this series was to ensure that we create awareness about obesity and how obesity is a major disease. So I think, having said that, all these programs are available on DocPlexus platform and also on our website. So if anybody has missed out on any of the program, you are most welcome to go through the recordings. And if there is anything else, you can either write to DocPlexus or directly approach us, and we'll be happy to help you. Thank you so much.
Thank you so much, Dr. Goel. And also thank you to Dr. Gupte for such clinical insights on this topic. I would like to thank Mr. Nizar for coming on the platform and talking to us and motivating many like him to come forward. To our dear doctors who are watching us here, thank you so much for all your support and interaction for this series. This was the final session for the CMS series, and we will soon be back with new series in the coming year. Until we see you again, please take care and have a great evening ahead. Thank you so much.
Thank you so much.
Thank you, sir.